Welcome everyone to tonight's inaugural presentation for the IPMS New Practitioners Group. We are excited to have Dr. Ed present this coding program, and we would welcome your thoughts and ideas on future quarterly presentations. We are recording tonight's coding session and will make it available to members as well as a copy of tonight's slides. Additionally, if you have any questions, please type that into the chat screen at the bottom, and Dr. Ed will take questions at the end of the presentation. So Dr. Ed has been involved with the IPMS for many years. He has been a former board member, president of IPMS, director of the Insurance Advisory Committee, and the CAC representative. Nationally, he has been a chair of the APMA CAC committee. He has also served on the APMA Health Policy and Practice Committee for the last 13 years, and as a chair of that committee for the past 2 years. Dr. Ed has lectured on coding and policy locally, regionally, and nationally. Currently, Dr. Ed is retired from private practice after almost 39 years. He is a certified coder with certification in surgical foot and ankle coding with the American Academy of Professional Coders. He also currently serves as the IPMS insurance consultant. In this role, he assists the IPMS members that have specific coding or insurance issues. He enjoys retirement, spending time with family, friends, and pets, working in his yard, and playing guitar. Let's welcome Dr. Ed.
Thank you, Kelsey. Before we get into the presentation, I just want to thank everybody for giving up your valuable time this evening to attend this webinar. Having been in practice for as long as I do understand that once you're home, that's your safe haven, and these type of interruptions hopefully can be worthwhile. Now, we developed this a program here for the newer, or what we call the younger practitioner, but I also feel that even the seasoned practitioner should be able to obtain some benefits from attending tonight's session. So what we're going to do today is I'm going to establish the foundation of the whole coding and billing process, because there are certain concepts that need to be understood. And then at that point, for future webinars, if we continue this, then we can do deeper dives into some of the more complex issues or very specific subject matters. And we'll talk a little more about this at the end. But for the time being,
Dr. Ed, I think you're muted.
Oh boy, am I sorry about that. Okay. Well, I won't repeat everything I just said, but I just want to thank everybody for attending tonight's episode, and say that what we're going to do tonight is build the foundation for other webinars in the future, or other subject matters that we'd like to do deeper dives into. But before we can do that, we have to make sure everybody is on the same page with some of the basic factors that apply to the whole coding and billing scenario. So let me see, here we go. Okay. Okay, now this is titled The Basis of Coding and Billing, but I probably should have titled this as The Mechanics of Coding and Billing. And this is just some of what I still am involved with here. One of the things I do want to point out is that I'm chair of the APMA Health Policy and Practice Committee, and just got appointed to another one-year term that starts next month. And in my role as chair of that committee, I run across all the problems that's happening all over the country, and certainly do have a pretty good grasp on what's going on with our profession. I really have no conflict of interest, except I have to mention that IPMS does have a financial relationship with me as an insurance consultant. And of course, I have to do a CPT disclaimer. And there we go. Okay, so on this first slide here of the webinar, what happens is that we start with a medical service or supply. It's your patient encounter. Then we go to the documentation, we do all that, and then either we as the provider or our coders, if we're in a clinic, will code the visit, submit the claim goes to the insurance company, the claim gets adjudicated, And then at that point, you either get reimbursed or denied. And everybody's aware of that. Now, with Medicare, what happens is that there are two options that occur with a Medicare denial. And one of them is for statutorily non-covered services. And typically, a good example of that is orthotics. Medicare does not cover orthotics. And because of that, we do not need an ABN, and we can bill the patient for these non-covered services. Now, the opposite of that is the non-medically necessary, where no ABN, if you do not have an ABN, it's a provider's responsibility. You just have to kind of eat that charge. But if you have an ABN, then you can bill the patient. So what's not medically necessary? Well, the classic example is that routine foot care patient that comes in, wants to come in every 6 weeks. And we know that they have to wait 61 days before they're eligible again for the at-risk foot care. So they come in at 6 weeks, you haven't signed an ABN, and if they want, ask you, you have to send a claim in, and you indicate that with the GA modifier. And what happens is that you get denied any reimbursement, but you do get to bill the patient. Now, Medicare sets the standards for all insurers all over the country, private and otherwise, even Medicaid. And everybody piggybacks off what Medicare does, although they tweak it to suit themselves, whether it's Blue Cross Blue Shield or Aetna or Coventry, or the Medicare Advantage plans, Medicaid, it doesn't matter. Everybody looks to Medicare. And for the fee schedule, the policies, and especially in the private sector for the edit policies. And we'll look a little closer at those edit policies in just a little bit.
Hey, Ed, I don't think your slides are progressing.
Oh, okay, they are on my screen, Kevin. Let me stop the share, Kevin.
Okay.
Let me start it up again to see if they are. I apologize for that. Okay, yeah, can you see that map, Kevin?
Yep.
Okay, let me talk about that, then I'll go ahead and advance that. If it's not advanced, I may need for you to do that for me, so we'll see. But anyway, these are the Medicare jurisdictions. We have 12 jurisdictions, and we have 7 MACs. Okay, and the MACs are the ones that administrate the Medicare program in these various regions, and I'm sure everybody's familiar with at least some of this. And as you all know, we're in the WPS J5 jurisdiction. Okay, did that advance, Kevin?
Yep, good to go.
Okay, thanks. If that happens again, please interrupt me. Okay, now I put up the Medicare physician fee schedule because at the end of this program, we're going to test everybody you have to repeat everything I've got on there if you want to get credit for today's webinar. And no, I'm just kidding. Okay, the real reason I put this up there was to let you know that the fee schedule is a very complex formula. And the things I've highlighted in red there are the reason why we see a difference if we perform a procedure in our office versus if we go to a facility. And typically we think of hospital as the facility. And that has to do with the practice expense portion of this formula. If you're at a hospital, you don't have staff, you don't have supplies, et cetera, et cetera. And so Medicare and everybody else is going to pay you less because of that practice expense portion there. Now, Medicare policies, they come in 2 different forms, the local and the national. And with the local, we have the LCDs, or what we typically refer to as policies. And these are applicable only to the MAC jurisdiction that developed the LCD. Along with the LCD, there's an associated local coverage article, which has all the details about the billing and coding, including the CPT and ICD codes. Now, on a national level, we have national coverage determination, which apply all across the board to every MAC, every jurisdiction. And CMS develops these, and the MACs cannot override these. Now, what I did is I took a screenshot of the WPS LCDs, which you can get on the WPS website. And I would encourage people to go to WPS website and download the applicable LCDs and become familiar with them. And as we get into this program tonight, hopefully should become obvious why we need to do that. Now, on the CMS side, if you want to look up the national coverage determinations, you need to go to their internet-only manual, and you can get to the CMS website, www.cms.gov. And from there, you can look around and come across these internet-only manuals that contain the LCDs. So LCDs are developed to define the appropriate use of new technology or to address services, treatments with an abuse history or potential, or for high volume, high dollar services. Everything that we bill for is not covered under an LCD. And so, I mean, for instance, if we don't have an LCD on bunions or hammer toes, and yet Medicare does pay for those because the payment is based on medical necessity versus an LCD. But LCDs also have medical necessity within them. So my point to that is not everything has an LCD. And I haven't counted how many LCDs we currently have, but we used to have a lot more than what we have now. But over the years, some of these have been retired. And the anatomy of the LCD has this general type of information. The three that I highlighted on there are very important for information, for documentation mainly, but also will assist you in your coding endeavors by knowing the type of things that are covered. And within the documentation portion in the LCD, they tell you exactly what your records need to contain. Also, some of this information is spread over into the utilization guidelines. So it would behoove everyone, for instance, like on the wound care LCD, to see what the documentation guidelines are and what the utilization guidelines are. And that way you can form your template to have all this information in it. Now, the policy article, and specifically the coding and billing article, has all the codes that were used to be contained in the LCDs, but now are in what's called the LCAs of the local coverage article. And I'm sure everybody's aware of that. And if a code is not listed in that LCA, you're not going to get paid for it. So whenever you are billing for something and you're not sure what's going to be covered under that particular LCD, go to the coding and billing article and look up the ICD code and see if that diagnosis is there. So now we'll switch gears a little bit and look at the DME, the MAC, the DME's MAC jurisdictions A, B, C, D. We got two MACs that provide all the coverage for the 4 jurisdiction. And what's important here is you have to build a jurisdiction where the patient lives, not where they obtain the service. And a good example of this is like a lot of the snowbirds that leave Iowa and Nebraska and head down to Florida for the winter. Something happens, they need a cam walker, they get it supplied to them, but we have to bill, whoever does it down there has to bill Noridian because the patient resides in Iowa or Nebraska, for instance. Okay, and here's the DME jurisdictions here on the map. And again, everybody's aware of that type of thing, at least that we're in Noridian. Okay, so let's switch gears a little bit and look at coding for a little bit. The codes that we are going to be referring to are CPT, ICD, and then what's classically known as the HCPCS codes. And CPT is owned by AMA. And when you are coding, you have to fulfill all the details of the code definition. And what I mean by that is you can't look at a CPT code and say, oh, this kind of looks like what I did on that patient. No, it can't kind of look like it. It has to look exactly like it before you can bill or utilize that CPT code. And as mentioned, it may require modifiers. So let's look at modifiers for a little bit. And this is just definitional stuff because you'll hear these terms tossed around. And I used to think, well, what are they talking about here? But when we talk about modifiers and we talk about level 1 modifiers, we're talking about the CPT modifiers, the 2-digit ones, the ones that we're all familiar with, the 25, 57, 59, 99, 76, 78, all of these. But when we talk about the level 2 modifiers, these are modifiers that CMS has come up with, and they're 2-digit modifiers. And those are like some of the examples on the bottom. And again, the terminology is not what's important. It's just knowing that CPT has control of certain modifiers and CMS has control of certain modifiers. Now, speaking of modifiers, there's modifiers fall into 2 categories: the functional type, which affects pricing, and then the informational type, which does not affect pricing. And as a general rule, you always want to put the functional modifier in the first position, okay? And that'll be usually those CPT modifiers. Okay, now I put the 25 modifiers as an example here because this is something that most of us use. If you are doing a procedure and an E&M on the same visit, the E&M will need to have the 25 modifier. It would behoove all, especially the newer practitioners, to go to the APMA website at the bottom where the URL is there and look at that 25 modifier proper use guidelines. We developed this at APMA. It's about a 10-minute read. You can read all about 10 or 12 minutes, and it will certainly explain exactly what you need to qualify for using that 25 modifier when you are doing a procedure at the same time. Because in this day and age, we're seeing a lot of denials for the E&M, payment for the procedure, denials on the E&M, even with the 25 modifier. But if your medical records are complete, should be nothing to worry about if you do it properly. And I'm not going to do that during today's session, but that's something that we can get into on a future webinar. And with the 57 modifier, this is the decision for surgery. The 25 modifier that we just looked at is used on your minor procedures that have a 0 or 10-day global, and the 57 modifier is used on those procedures that have a 90-day global. And for an FYI, the 57 modifier starts on the day before a procedure is performed. So you get called into the hospital, you do an H&P, evaluate the patient, decide to take them into surgery the next day. On that E&M that you did the day before the surgery, you have to put a 57 modifier on it. Okay. The 59 modifier starts becoming a little bit more complicated. It is defined as distinct procedural service. It is a modifier of last resort, meaning that if there's other modifiers that you can use other than the 59, it's preferred. Okay, and there are some examples, the anatomical modifiers, the RTLTs and the T modifiers, and that way you don't have to use the 59 modifier as much. And the 59 modifier is under a lot more scrutiny and is audited a lot more. But if you use the anatomical modifiers, or if that doesn't work and you have to use the 59 modifier, consider using the X modifiers, the XS or the XU. And the 59 modifier or the anatomical or the X modifiers are used on the NCCI column 2 codes, and I'll have an example of that in just a little bit. So the 59 modifier is used on procedure or service codes and not on E&M codes. Okay, ICD-10, just real briefly, there's 2 versions of this, and we currently are using ICD-10, but we use the CM version in our offices and clinics, the clinical modification. The PCS version is the procedure coding system, and that's used by hospitals to report inpatient procedures. It has nothing to do with us. So if you're purchasing these books, make sure you get the CM version. And I just wanted to review a little bit of terminology that we see in ICD. Excludes 1 and excludes 2 are commonly get confused. But if you look up a code and it has excludes 1, that means the examples that are listed can never be used with the diagnosis that you're looking at. If it says X2 excludes 2, and it gives a bunch of examples of different diagnoses under that excludes 2, those are diagnoses that you can use with the diagnosis that you're referencing or looking up. And the next one is kind of something that is confusing as well. When you see the word "and" in these definitions, descriptors of the ICD codes, it means either and it can mean or. And when you see the words with or in, it means associated with or due to. And so these can be a little confusing at times, but if you keep that in mind or reference this, then it may hopefully make more sense in the future. Now we talk about HCPCS, and typically when we talk about HCPCS to each other, we're talking about HCPCS level 2, and these are the codes that we use for DME. HCPCS level 1 is CPT. And again, that's just for informational purposes in case you find some coder or somebody that's referencing level 1, level 2 HCPCS codes, you have an idea of what they're talking about. Okay, so now let's switch gears a little bit and look at NCCI for a few minutes. NCCI procedure to procedure edits prevent improper payment due to unbundling or fragmenting codes. There's two columns. The column 1 code is the comprehensive code, and the column 2 code is the component code. And NCCI is something you should be referencing anytime you do more than one procedure to make sure that your second or third procedure is not bundled into the primary procedure or vice versa. Now, when you look up NCCI, and if it has an indicator of 1, after that column 2, it'll tell you the indicator. If it has 1, that means you can bypass. You can break it out. You can unbundle that code. And let's use an example. Let's say you do a bunion on the left foot and a hammer toe on the right foot. Well, a hammer toe is a column 2 code to the bunion code. Okay, but you're doing them on different feet. Okay, which is real obvious that you should get paid for both procedures. So the indicator for that column 2 would be a 1, meaning that you can bypass that edit, bill for it using a 59 or one of the other modifiers that I mentioned, and get paid for it. If it has an indicator of 0, you cannot use any modifier to bypass that edit. So don't be surprised if you get denied on a secondary or tertiary procedure if the indicator is 1. And if the indicator is 9, ignore it. It means that that edit used to exist, but no longer exists and has been deleted. And here is examples of the those indicators there that I mentioned. And I gave some examples of column 1 and column 2 codes. And if you look at the bottom there, it has an indicator of 0, meaning that you cannot bill for a 99202 when you're billing for a 99203. And that's pretty obvious. Now, some of the other ones are not quite so obvious. And that's why it's a good idea to look these up before you bill. It'll save you a lot of headaches. You'll know which ones require modifiers, which ones can use modifiers to unbundle, and which ones you can get paid for, and therefore which ones you can appeal if you need to. Now, medically unlikely edits is another type of edit program developed by NCCI or CMS, actually, and it's part of the NCCI editing. But it has to do with maximum units of service. And for instance, you cannot bill 3 bunion codes on the same patient on the same date of service, and that's pretty obvious. But some of the other ones that when you look them up, you wonder, why is this, why do they have this maximum units of service? I'm doing more than what they allow. And that's just to put you on notice that you may not get paid for those additional procedures. And you cannot bill a patient for excess MUE, even if you haven't signed an ABN. So if the MUE says 4 and you bill 5 or 6 of those procedures on a patient, those last 2, you cannot bill the patient for. Okay, and here's some examples of some MUEs. Like for the last one, the 11750 PNA procedure, or matrixectomy, you can do 6 of those at one visit. And a bunion procedure, 28296, distal osteotomy, it has an MUE of 1. So that means what? You can bill 1 bunion per session. Actually, this gets a little more complicated, and this has to do with the bilateral modifier, and I don't want to get into that with this session, but basically 28296 is subject to the bilateral modifier, and so you have to, if you do bilateral, you bill on one line with a 50 modifier and 1 unit of service, and when you bill that 1 unit of service, you'll qualify for this MUE of 1. Okay, now we're going to switch gears again and look at DME. And there's 4 areas that we have concerns about: coverage criteria, documentation requirements, proof of delivery, and correct coding. And we're going to look at a few of these here. First of all, your standard written order. This is your prescription. Well, what you have to do here is you have to wear 2 hats if you are a supplier. Because as a provider, you are the prescriber for DME. And if you are also a supplier, then you have to put a different cap on and look at things from a different standpoint. So as a supplier, whether you refer that patient to a medical supply place or you do it in-house, you have to have a standard written order somewhere in your medical records. Now, this is critical, because it's the prescription and you need every single one of these items. And what I used to do, I would just template this and get pretty specific on the type of things that we would dispense out of our office, like cam walkers, for instance, or some of the other AFOs and night splints and things like that. And I would have a template set up with all these factors in there, so that when I got audited, there would never be a question about whether I had everything. These auditors, they look for each and every single one of these items. And if they're not there, they're going to ask you to reimburse them, or they're going to deny a claim on a pre-service review. Now, there's an exception to that. If you, in those circumstances where this provider is also supplier, the SWO is not required. But the caveat is that all those elements that I had on the previous slide, you have to have that somewhere in your notes anyway. So to me, it's easier to just put it into a little mini template and incorporated it into that day's visit. And that way you have each and every one of those line items covered, and no auditor is going to get the best of you. Okay, so let's talk about proof of delivery just for a little bit here. These are the items that you have to fulfill this requirement of proof of delivery. The DME auditors, to me, are a little bit more distinct, and they look at all these elements here when they're reviewing medical records to see if you have all these items, as I mentioned before. And it would behoove you to make sure that on the proof of delivery, when either you're dispensing that AFO out of your office, dispensing a cam walker on the day that you saw a patient for an injury or whatever it is, you have to have all these elements in there. So it's something that you can refer to. And you have to have a proof of not only that you delivered, but exactly what you delivered. So you have to have a narrative description, a HCPCS code, or the definition of the HCPCS code, or brand name, model number. And the method of delivery, there's 3 methods of delivery: directly to the patient, as most of us usually do out of our clinics or offices. But there's other ways of doing this, but some of these don't apply to all items. For instance, via shipping. Technically, you can't ship diabetic shoes because you have to do a fitting, and you have to have documentation in your records that the shoes and the inserts fit well. And you can't do that if you dispense that being a shipping method. And at the time of delivery, these are the documentations that the patient had, and I had a mini template for this. And what I did is just said these are the items that were, the documentation dispensed to the patient. We also had a form that they signed saying that they received all of these things. Okay, the KX modifier is an interesting one. The definition of this, and we use this mainly on the DME side, is requirements specified in the LCD have been met. So when you put the KX modifier on that cam walk, the L4361 code, you're saying that you're doing everything that the LCD requires of you in order to dispense and bill for that particular cam walker or whatever the device is. And Medicare will go ahead and pay you for that. Now, this is an interesting slide because it has the 2018 Part B Medicare data, and that 18 is the most recent that we have. But if you look at the HCPCS codes in that second column there, These are our orthotic codes. And if we look, Medicare pays for these. So why does Medicare pay for orthotics if they're not covered? Because when somebody bills for them, they put the KX modifier and Medicare pay for it. So there's one instance where Medicare does pay for an orthotics, and that's if it's an integral part of a covered brace and shoe. And if you put a KX modifier in an orthotic, you're saying that have dispensed the brace to the patient. The brace is affixed to the shoe, and the patient needs the orthotic in the shoe for the brace and the shoe to function properly. And the supplier of the orthotic has to be the supplier of the brace. And so I caution everybody on this: do not bill Medicare for orthotics unless the patient demands it, because maybe they have a secondary insurance that might cover it. But you would have to put the GY modifier, which is a different subject matter, GY modifier on this. Do not put that KX modifier, because if you do, Medicare will pay you for the orthotics. Let's look at documentation for a few moments. Documentation is your only protection on prepayment reviews, post-payment audits, appeals, and recoupments. Now, I put this up there because I took a screenshot of the documentation requirement from the WPS Wound Care LCD. And if you read this, there is a lot of stuff in here. We won't go through it on today's webinar. But again, as I mentioned earlier, you need to read this. You need to see what you need. Wound care is a highly audited the codes using wound care, the highly audited codes. With that, you better have every single little thing that is indicated. Now, not only in the wound care, but the AFO, the surgical dressings, just any of these LCDs that apply to you and your practice, you need to see what the documentation requirements are. This is what fouls up most people on these audits and recoupments. And I have reviewed a lot of charts, and it always bothers me when I have to go back to that practitioner and say, sorry, you don't have a leg to stand on because you don't have this or this in your documentation. Now, this is something I got from the DME, the Noridian DME website, and it has to do with surgical dressing. And this tells you what you need in your records in terms of documentation if you're going to prescribe some of these wound dressings, wound care dressings here. And so, for instance, if they have a minimal exudate, well, you're not going to be using a foam dressing or an alginate dressing. And so this is a good thing to have available just to make sure that if you do prescribe surgical dressing, that you fulfill the criteria for these. Okay, and one of the things that we see all the time on these reviews, and whether it be a TPE or any other kind of review, top reasons for denials. Now, this is from Noridian DME. The medical record documentation does not support blah, 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 blah. You know, in this case, that the patient was ambulatory. But we're seeing this as always one of the top reasons for denials. The medical record documentation does not support, and then whatever it doesn't support. In this example, that the beneficiary is ambulatory. And I see a lot of reviews happening, and because we didn't put that in there, we didn't think, you know, the patient is ambulatory. Well, you know, that's a statement because they walked into the office, they walked into the treatment room, they walked out, and we just assumed, well, they're ambulatory, but you have to have it in your medical records. Okay, now real quick on appeals. This is just, again, for information purposes. There's 5 levels of appeals. The first one is with the MAC, and the other 4 are outside of the MAC. And this is just information on how many days you have from the denial to submit those appeals. If you have the appropriate documentation that's going to carry you through one of these appeals. And so we don't need to talk about that, but this we need to mention a little bit. There are no appeals under certain circumstances, unprocessable claims that are rejected because they're unprocessable. Maybe they had the wrong Medicare ID number, the wrong address, wrong name, whatever it is, that they do not have appeal rights. on those, you have to correct the error and resubmit it. If you go over the timely filing limit, that 1 year with Medicare, if you don't submit a claim within 1 year of the date of the service, you can't submit that claim. And not valid for Medicare purposes is another remark code that is why a claim gets denied, and those do not have appeal rights, just like non-covered services. You can't appeal non-covered service. It's going to be non-covered whether you appeal it or not. So there's no point in doing that. And Medicare doesn't want you doing that either. And these are the auditing entities, and there's tons of them out there. And the chance of people getting audited, pretty good. If you haven't been audited, get ready. You will be at some point during your career. So I want to go over a few pearls, and I know I'm going over a little bit here. And sorry about the mess up at the beginning of this webinar, but we will have time for some Q&As. But I want to share some pearls that I've learned over the years, or that I've run across with different practitioners, charts that I've reviewed, meetings that I've gone to, etc. First pearl. And the reason I put this up there is that right now, Noridian SMRC, SMRC, supplemental review medical contractor, is doing audits, and they are doing hot and heavy audits on routine foot care or at-risk foot care. And what they're deeming practitioners on is if they say the patient has non-palpable pulses for the class findings, they're saying that does not equal absent pulse, and they're denying those and requesting recoupments on those. And then we had a meeting on this at APMA and discussed this. And one of the things that I brought up is, does 0/4 equal an absent pulse? We're not sure. You look at this thing, well, of course it does. Just like non-palpable means absent pulse. But if you think about it, non-palpable really doesn't mean absent pulse. It means you couldn't find it. It doesn't mean it wasn't there. Maybe it was there. You couldn't feel it. Maybe you got a little neuropathy in your sensory neuropathy in your fingers, and someone else could put their hands there. And, oh yeah, I get a trace pulse there, 1/4, and you couldn't palpate it. So who's right? Well, listen, the LCDs that are out there, as well as the at the national level, when they talk about at-risk foot care, they talk about absent pulses. Best rule of thumb, use their terminology and you can't go wrong. Okay, now this looks like a complicated slide, but I'll break this down real quickly. And I've run across this a lot. I've been asked, well, why did I get denied on, these injections or the surgery that I did for Morton's neuroma? Well, Morton's neuroma has a bilateral indicator, which means if you do it bilateral, and you'll say you do injections bilateral, or you do excise them bilaterally, or whatever you're doing to them, you bill it on one line with the 50 modifier and 1 unit of service. Okay, and then you submit the claim. Because if you look at the ICD codes, they have it, unilateral, right, left, or bilateral. So you would not use the left and right ICD codes. You would use the bilateral ICD code. And that would go to the bilateral procedure with the 50 modifier and should get paid. And the people who have resubmitted claims have gotten paid once they did properly. Now, this is something I run across fairly often. Talk about routine foot care. Now, routine foot care, by the way, is statutorily not covered. It's an uncovered service. What is covered is the exception, which is at-risk foot care. And this is where we have the systemic illness and class findings. And then the other pathway is the mycotic nails with the difficulty in ambulation or the pain. And I see a lot of practices that combine these two together. So a patient comes in, they got 6 painful, thickened mycotic nails. They happen to be a diabetic with good pulses, but they qualify under the mycotic nail portion. So you debride the 6 nails, submit it, but you also used diabetes, thinking, okay, I'll just, add a little fluff to my diagnosis, let them know they're diabetic. Well, guess what? Once you put diabetes down, now you have to have MD, date last seen, last visit, and you have to have your Q modifiers. Because with mycotic nails, you don't have to have those class findings and the Q modifiers. But if you put down diabetes, peripheral vascular disease, and these kind of things, you're going to have to go with the class findings and the MD, DO, and date last seen type of concept. So pearl number 3, don't combine them. Use one or the other. And if you're not sure what I'm talking about, we can discuss this on another episode, another webinar. Just real quick on excision of benign lesion, Medicare and most private insurance do not cover these for cosmetic purposes. So your notes have to indicate that the patient's having some kind of problem. It could be pain. It could be that they have a fibroma, and every time they shave their legs, they're cutting their fibroma on their leg. Whatever it is that requires will lean toward a medical necessity that requires you to excise the lesion and bill it. And so make sure that you mention something for medical necessity when you're taking out benign lesion. And that includes warts, by the way, okay? Skin tags, epidermal cysts, sebaceous cysts, whatever. Okay, real quick, complications during surgery. The pearl on this is CMS has their definition on complications, and this is what most of us are familiar with. In other words, patient comes back for their first post-op check and say, oh my gosh, they got an abscess under that, surgical site. And so you pop a couple of stitches, you incise and drain it. Well, Medicare says we're not going to pay unless you take the patient back to an OR. And then you use the 78 modifier to let them know about that, and everything's hunky-dory. CPT, however, is a little bit different. If you have a complication that's not the normal course of events, CPT says you can bill it and get paid for it. So what the pearl is here is that if you're dealing with private insurance and the patient has that scenario I just mentioned, and right there in the exam room, you pop a couple stitches, you drain a hematoma, or you soak the wound because it dehisced, or whatever you did, bill them for it. And use the 58 or 78 modifier for the procedure that you did. And again, that's for private insurance only. Okay, pearl number 7. AFO modifiers. They could be in any order. Remember before I said with CPT modifiers, you want to put the payment modifier first before you put the informational modifier. Well, with DME, you can put that KX modifier or the LT modifier. It doesn't matter what the order is, they'll still pay you for it. So don't have to worry about DME. And then the last thing I already mentioned before, if you're doing anything except the night splint, meaning in the AFO category, you're doing anything other than night splint, mention in your notes that the patient is weight bearing, because practitioners have gotten dinged on this in the past. Okay, I have another one here. Okay. When you're doing anatomical modifiers for NCCI edits instead of the 59 modifier, you remember I said the 59 modifier goes on the column 2 code. If you're doing anatomical modifiers, meaning you've done 2 procedures, you're doing right foot, left foot, you got to have the RT and LT. You got to have them both. You got to have them on both codes, the column 1 and the column 2 codes. Otherwise, you'll get denied on that. Okay, I threw this out there because this is a pearl that we talked about at the coding committee meeting a few months ago. Okay, a patient comes in, they have a localized abscess, subsecond bedhead. You numb it up, you incise and drain it. Is this a simple IND or is it a complex IND? And the reason I put this up as a pearl, if you incise and drain it, you numb it up, incise and drain it, you wrap it up, you send them home, antibiotics, no antibiotics, whatever, you have them come back for a follow-up, etc. That's a simple IND. If you pack the wound with anything, any kind of packing, it becomes a complex IND. If you search CPT, you search coding websites, they will not tell you this because it's never really been defined. But we know that at APMA, we have found out if you pack the wound, you can bill a complex IND, and it has a higher RVU value as well. So that's it on my presentation, and sorry about that, but we're going to still have a good 15 minutes to have Q&As. But I also wanted to mention that we're thinking about doing future webinars if there's an interest in this. We just need to know what you were interested in. Today's webinar built a foundation. And from there, we can go off in a lot of different directions. And I just put a few suggested topics on some common things that I've lectured on or have heard lectures on, or that a lot of my colleagues have lectured on at different seminars, et cetera. But if you have any ideas or like to see a topic talked about, and we can do 2 or 3 topics even in one webinar as well if they're short subject matters. Let IPMS know. And the last thing I want to mention before I turn it back over to Kelsey or Kevin is that in Iowa, part of my function is that I answer questions that have to do with coding and policy and insurance, et cetera. And so if anybody in Iowa, if you're an IPMS member, you have a question about anything, that's the way to get a hold of me. And within usually 24 to 48 hours, I'll have an answer for you, some form or another, even if it's, I don't know, but I'll at least have an answer for you. So listen, I want to thank everybody for giving up your evening today to listen to this foundational webinar. And I think we'll be ready to entertain questions, and I'll remove the screen sharing and give it back to you, Kevin and Kelsey.
We have a couple of questions already in the chat. So for the first one, someone's wondering about E&Ms based on time, if they should specifically document the start and finish times for each of the encounter components.
You know, that's a great question. And as everybody knows, there's 2 ways to start this year on all these E&M services. Now, 2 years ago, they did the office and outpatient, but now all the E&Ms based on medical decision-making or time. The thing on time, and you'll hear different things from different people, different authorities. They'll tell you, yeah, you'll just like you time clock. You clock in when you go into the room, you clock out when you're done or when you're done with your records, et cetera. No, there's no requirement that says you have to have a start and stop time, but you do have to proportion out your time. You know, somewhere in your medical records, I spent 20 minutes with the patient, 10 minutes on my dictation, 5 minutes talking to the patient, 4 minutes on a phone call to their MD, you know, whatever it is, you do have to break it down so that you can reach that threshold and no auditor can touch you then. Yes, Kelsey.
Okay. Yep. The next question is, when you're doing more than one procedure for any given encounter, can you provide general rules for which procedures to amend with the XS or 59 modifiers?
Yes, the column 2 code. So how do you know which is the column 2 code? You know, there's a lot of times you don't. Sometimes it's pretty obvious. Let me give you that obvious example. Let's say in your office, you're doing a hammer toe procedure in your little minor surgical room. And so you schedule it, the patient comes in and they tell you, doc, you know, while I was coming up the office, I dropped something on my other foot. And you look there at the foot, they've got a laceration. And you look at it and say, oh, it's pretty clean. We just need to clean it up a little bit and put some sutures in it. Okay. To me, that's pretty obvious that that laceration is going to be the column 2 code to the hammer toe correction. Because in a hammer toe correction, the global package includes the suturing. So if you make a decision for a procedure, the global package includes the suturing, just like it includes the dressings, the post-op instructions, and you know all these supply kind of items and procedural kind of items. But sometimes it's not so obvious. And it's like the other example I give: when you do a bunion and a hammer toe, well, yeah, the hammer toe is kind of a less aggressive procedure than your bunion code, and you can probably deduce that the hammer toe is going to be a column 2 procedure. But that's not always the case when you start talking about arthrodesing procedures and ankle procedures and things like that, where you're involving major tendon procedures and stuff, which is the column 1 and column 2 code. The answer to that is twofold. You can download the NCCI tables from the CMS website that I referred to, cms.gov. And you do a search on it, and it'll take you right to download it, and you'll have an Excel spreadsheet, and just look up either code, and it'll tell you which is the column 1 and which is the column 2 code. An easier way, if you subscribe to the Coding Resource Center on APMA's website, they will have that information for you. And they have an NCCI tab, and it'll tell you which ones get to 59 or the excess. XSSU modifier or the anatomical modifiers.
And then the next question is just asking to kind of review the 59 modifiers, when to use it and when not to use it.
Okay, and this is a good point. I'm glad you brought that up because there's a lot of times I see people, okay, I did 3 things on this patient today, and on my big procedure that I did, I'll just put that as is. But on the other 2 little more minor things, I'll just throw a 59 modifier on them. And that's a bad thing to do because I have seen procedures get denied for use of a modifier where it was not applicable. If the second or third or fourth procedure that you do is not a column 2 code to the main procedure, do not put any kind of modifier. Do not put a 59 modifier on that to break it out of the column 1 code. If there's no procedure to procedure edits, you do not need a modifier on that second procedure. And I'm hoping this answered your question, but I'm glad you asked it so I could throw that in. Don't just be throwing modifiers out there and appending them to just like on that orthotic. You put that KX modifier where it wasn't warranted and Medicare pays that orthotic and you think, hey, great, Medicare's starting to pay for orthotics. Until you get audited and until you get measured for that orange jumpsuit, I'm just kidding there, but well, practitioners have been thrown in prison for fraud. Medicare fraud, and you don't want to go down that road at all. And that was with the KX modifier, not the 59 modifiers that we're talking about here. So I hope that answered your question. If not, please re-ask it.
That's all the questions we currently have, unless someone has a question. We have a few minutes left before the top of the hour, so.
Okay, well, we can wait a minute or two and see if any other ones come through. And while we're waiting, I'll just mention a couple of things that I went through before. I just wanted to make sure I didn't go over that too quickly. You know, I had a lot of material I had to cover, and I have honed this presentation down from when I first put it together, because I thought, oh my gosh, I'll be talking well over an hour if I talk about everything that I have. So I started removing things and started minimizing some of the presentation on certain things. But I want to go back to that 25 modifier and the to mention that that is applied to E&M services when you're doing a procedure if you have a separate E&M service that you can bill for. And it doesn't matter if they're a new patient or established patient. You have to fulfill the requirement of significant and separately identifiable. So if you're doing a 0 or a 10-day procedure and you're doing an E&M, use the 25 modifier. If you're going to be doing a 90-day procedure that has a 90-day global period, then you would use the 57 modifier on that E&M service. And you know, it doesn't matter if you did it the day before or the day of the major procedure, it still requires the 57 modifier, or they will kick it out and deny it. But it still has to be separately identifiable in regards to the content of it. And that's why I recommended that everyone go to the APMA website for that 25 modifier, look at that 25 modifier slide for the URL, and take the 10 minutes to read the content of what is required to be significant and separately identifiable, whether it's for a 90-day procedure, or an E&M code that you do with a 90-day procedure or 0 and 10-day procedure along with E&M.
We do have another question, Dr. Ed.
Okay, thank you.
This person travels to 2 satellite clinics and dispensing DME from, he says he will dispense DME from his main office. So can I dispense DME to all sites under that license?
Technically, my understanding is the answer is no. You do have to register each site to be a supplier from those sites. This is something that has come up before. I know it's kind of a confusing thing, and I've heard different answers to this, but the last time I checked on it indicated that you have to Your billing site is in this case is where you dispense it. And if you have 2 or 3 different offices, each site needs to be registered.